Well, good afternoon, everyone, and welcome to Ask the Docs, a Fertility Institute of Hawaii live stream. This month, our topic is pre-implantation genetic testing, or PGT, right for me? Thank you for joining us. We have a lot of great information to explain to you today, and hopefully some good teaching points for everyone. My name is Dr. John Fraterelli, and I have Dr. Anat Carmone and Dr. Emily Goulet here with me today. And we're going to have hopefully a very lively discussion. I guess we'll start with maybe Dr. Goulet. You want to maybe tell us a little bit about PGT and what is it?
Yeah, so pre-implantation genetic testing, formerly known as PGS or pre-implantation genetic screening. You may also come across PGD, pre-implantation genetic diagnoses. These are some older terms you might see in some of the forums and whatnot, but nowadays we use the term PGT. It is the testing that we can do on an embryo. For us here, it's on a day 5, 6, or 7 embryo, where we take a small biopsy of the embryo from the part of the embryo called the trophectoderm. That is the part that will later on develop into the placenta. So we don't touch the baby, we don't harm the baby when we take these cell samples. And it's only a handful of cells. We typically don't take more than five or six cells when we do this biopsy testing. We send these cells off to a mainland genetic company where they do some genetic analysis and return to us a report that tells us, does the embryo have a normal set of chromosomes? So 23 pairs and either XX for a female or XY for a male. So with that information, we can help better pick the embryo that we would use moving forward for a transfer.
So one of the big things that patients usually tell me or ask me, they say, is this test right for me? I don't have any family history of any diseases. Okay, so this is a very important point, but just as Dr. Goulet was saying, there's a few different types of PGT, and certain types of PGT will actually look for specific disease. So if a particular disease runs in your family and you're a carrier for that, maybe your partner is also a carrier, we are able to actually test for that particular condition in the embryo. However, the majority of PGT is PGT-A, or PGT, Preimplantation Genetic Testing for aneuploidy. And that testing is really looking at that chromosomal complement. It's looking at the number of chromosomes within this embryo. It's also looking for, most of the kind of modern platforms are looking for deletions, duplications, so maybe there's some extra pieces of chromosome or pieces of chromosome missing, things like that. And the chromosomes are where we kind of have all of our DNA, but that's different than looking for a particular mutation which causes a disease. Okay, one of the most famous chromosomal disorders is Down syndrome, or trisomy 21. That's where there are 3 copies of the chromosome 21. Down syndrome typically does not run in families, right? And many of you probably are aware that it's most associated with maternal age. And that's because there are certain mistakes that are made as the egg and sperm start to divide. And that's kind of regardless of, again, family history, and more so related to egg quality, among other things. And so those mistakes can only be kind of picked up once that embryo has started to grow. And so it's not anything that, you as the patient would be born with. I would not be able to test you for Down syndrome, for example, or test your family, right? I would just be able to really test that embryo. And that is the most common type of PGT. The other thing that I mentioned to patients about this is that although Down syndrome is the famous one, it's compatible with life, the majority of the aneuploidies, or kind of those abnormal numbers of chromosomes, are actually not compatible with life, or are associated with early miscarriage or failed implantation. And so much of the time when we're doing this type of testing, we are doing it to determine which embryo is most likely to implant, which embryo is most likely to kind of result in a live birth. right? So if I have an embryo and it's abnormal, I'll stop talking like after this. If I have an embryo and it's abnormal, okay, but I didn't know it because I didn't do that testing, right? And I go ahead and transfer that into your uterus, and it's an untested embryo. What could happen? Well, most of the time, it's just not going to implant. It's going to result negative results. Some of the time, it's going to implant and end it with an early miscarriage if it's that an abnormality that's not compatible with life. On occasion, it could implant and end in a live born child with an abnormality. And as I mentioned, the famous one would be Down syndrome. There's a few other ones. But most of the time, we are utilizing this testing to determine which is that best embryo to transfer for you that's going to result in a baby. And so that is something to keep in mind when you're thinking about this type of testing. Dr. Frederelli, I'm sure you can jump in here and maybe correct some things I said.
No, you both are perfectly correct. I think that it is important to realize that PGT is this technology that we've had around for a couple of decades now that's really changed. And initially, when we first started using it, we were only able to look at a few chromosomes with a technique called FISH, which is fluorescent in situ hybridization, which would mark a chromosome with a specific color, and you could tell if there were two greens and two yellows and two reds, that at least those three chromosomes were present, or if it was missing one, that you were missing a chromosome. And now it's really just phenomenal that we're able to, with just taking a few cells from the placental area of an embryo, get a karyotype, get a chromosomal makeup of an embryo, and get the same information essentially that we would get from you and I if we gave 1 million blood cells to do the same test, a karyotype. It really is amazing that we're able to do that. And some of the benefits, as you were describing, being able to just choose that best embryo to put in, but not only the best one we think is the best, but the one we know is chromosomally normal as well. And that's going to allow patients to have less miscarriages, right? So, because otherwise you might have a miscarriage because the embryo is chromosomally abnormal. It's going to improve the live birth rate per transfer, allow patients to get pregnant quicker, and reduce the multiple gestation rate. That's one of the big things that we've noticed. Instead of putting 2 embryos in because we're not sure if they're normal or not, now we have a normal embryo. We can put 1 chromosomally normal embryo in and have essentially the same, if not a better, pregnancy rate than if we were putting 2 embryos that we had untested. And so that's very important for patients to be aware of. I guess what are the limitations? I mean, we talked about how great PGT is. I think we are very we're all. What are some of the potential limitations of it?
Great question. And so one thing that I get patients that I have patients ask me on occasion is, I want you to do all of the testing. I want to make sure that this is a perfect embryo. I want you to guarantee that I have a healthy baby when my baby is born. And unfortunately, there is no test that can do all of those things. There are limitations to every test. When I describe PGT, I say this kind of looks at the forest, but it can't see every individual tree or branch or every little gene or base pair of DNA. So there may very well still be genetic damage that is elsewhere on the chromosome, on a different chromosome, that this testing cannot pick up. There are also birth defects that are not due to chromosomal or genetic problems, such as spina bifida, which this testing cannot pick up. Every test has an inherent false negative rate. And so there is a very, very small chance that the embryo could be affected with something that could make it to a live birth and the test not pick it up. But in general, that's not something we're overly concerned about. The bigger limitations are the fact that it can't pick up at this stage in development all of the potential congenital birth defects that may result. And so for that reason, individuals are still encouraged to undergo the routine prenatal screening for congenital birth defects, whether that be the cell-free DNA, non-invasive prenatal testing, the anatomy scan, ultrasounds later on in pregnancy. all of those things that an OB in conjunction with an MFM would do to check to make sure that the baby is growing in a healthy and appropriate manner. Another limitation to the PGT is something called mosaicism. If you can imagine the outside part of the embryo, that trophectoderm, the part that becomes a placenta, as a soccer ball, there's different patches of cells, and we take a biopsy of a small patch. And when we get that report back, we think that that small patch of cells is representative of the entire embryo. But there is a possibility that there could be just a small population of cells that are affected with either an extra or a missing chromosome. And so our report could be skewed to make us believe that either the entire embryo is affected or not affected. More commonly, we'll get a mosaic report back that says, okay, 80% of the cells look normal, but maybe 10% may not be. And that's becomes a shared decision-making process with your doctor to talk about, is this an embryo that is a candidate for transfer? Is this something that you feel comfortable moving forward with?
So about mosaicism, I mean, it's such an interesting point, and there are many different facets of embryo mosaicism. So going back to the way we used to do things, we used to actually biopsy embryos at that day 3 stage, at the cleavage stage, which is where we would, take one cell from an embryo that was only 6 to 8 cells altogether. And then we would test that one cell. Those results were not nearly as accurate as the type of testing that we do. And that's because there is some degree of normal mosaicism in development. And so as embryos develop in those very early stages, there may be some abnormal cells which are just sort of taken over by the normal ones. And so when we were only testing one cell out of 6 to 8, you can imagine a situation where we found an abnormal cell, but then it would have been fine because the other cells sort of would have taken over the normal ones, right? The other issue with that, which isn't necessarily related to mosaicism, is that we would be removing a cell from an entire cell from a 6 to 8 cell embryo versus what we do now, which is Dr. Goulet was saying, we take a cell from that outer layer where there are many, many more cells present at that point. And we know that it appears that biopsying cleavage stage embryos did result in lower blastocyst development rates. So we knew that there was kind of some damage to the embryo, whereas now that does not seem to be the case. There is probably still some degree of kind of normal mosaicism, right? Because maybe not every cell is completely normal in that trophectoderm, and which is that outer cell layer. But the majority of the studies do show that there's pretty remarkable, what's it called? They're both the same, right? Between the inner cell mass and
concordance.
Yeah, concordance. Right. There you go. So it does appear to be a pretty accurate test. The other issue with mosaicism, okay, because now we're able to actually detect mosaicism because we're checking more than just one cell. There may be a readout that suggests that maybe some cells are normal and some cells are not, as Dr. Goulet was suggesting. And what do we do with those answers? There's kind of been a shift in thinking about those mosaicism results. So one possibility is that those cells are, actually we're getting normal and abnormal cells, right? The other possibility is it's sort of result of of the test itself, that there's just some noise in the test that may result in what kind of appears to be a mosaicism, but not really true mosaicism. And so the question is, how do we interpret these results where there isn't a clear result? It's very frustrating. But it does seem like for most mosaicism at this point, although those embryos may not be as successful as a chromosomally normal or euploid tested embryo, they do appear to result in healthy babies. They are typically transferable embryos, depending on the level of mosaicism, and talk to your doctor about it, which chromosome, talk to your doctor about it, and all that. But these are transferable embryos. And that is really a shift in thinking over the last couple of years.
One thing I like to mention to my patients who are on the fence, but it may be their only embryo left, is had we not done the PGT, were we only working with untested embryos, we would have transferred it not knowing, and it could have very well resulted in a live birth.
Well, I think that the thought process has certainly shifted as we've learned more about mosaicism, and and really a lot of the geneticists that are doing these tests really want to call it copy number variation, where it's really just kind of a fuzzy area of that embryo where we're not sure. We might know that the embryo is normal, but number chromosome 13 could be a little high or a little low. We're not sure that with that area, and so but the rest of the embryo is normal, and so you put that embryo in, and those embryos have a very good chance of surviving and making a baby. The pregnancy rates seem to be just a little bit lower, about 10% lower than embryos that we call chromosomally normal, and the miscarriage risk is a little bit higher, but they function very well. It's very they function almost as well as a normal embryo, and we haven't seen any mosaic syndromes be born from these embryos. That's the other thing to realize, is that there's no mosaic syndrome out there that we're seeing when we put in mosaic embryos, and there's no mosaic syndrome that we're seeing when we're putting in untested embryos either. And again, these embryos, if they were untested and we put them in, they still would, you either what you would have called it mosaic, you called it mosaic and you tested it, or you didn't test it, but you're going to get the same outcome. And there are some concordance. You were talking about concordance, Dr. Coleman. There are some studies that look at concordance with mosaicism, and the ones that found that if you have a high mosaic embryo, meaning that that's really more on the abnormal side than on the normal side, that those embryos are more abnormal, more likely to be abnormal. And conversely, the embryos that are on the low mosaic side, where most of the testing is pointing to it being chromosomally normal, when they do the concordance data looking at the rest of the embryo, that embryo almost uniformly tends to be normal, which is why you have very good success rates with these embryos.
Right. Another thing that I think patients do bring up as well is, well, how many of my embryos are going to be abnormal? It's like, yeah, I know that, Down syndrome and these things are common, don't get me wrong, but it's like, it's not like half of my embryos are going to be abnormal, right? Well, it's just mind blowing. Okay. But like, most embryos are abnormal. Isn't that crazy? It's just the craziest thing. And of course, that's very heavily dependent on age. Even in young egg donors, okay, we see up to 30%. And this is stats, right? So sometimes you can be 45 and have all normal embryos, although that's not as common, okay? But, in young egg donors, it's approximately 30% of embryos are going to be abnormal. And these are women in their 20s, right? And as you get older, it's you see more and more abnormal embryos. And up until 44 plus, where the majority of embryos are abnormal. And so that's why looking at studies that sort of looked at when PGT is really beneficial, right? Because if all embryos are normal, it's not going to help you, because this testing is not making your embryo normal. I wish it did. It's not making it normal or abnormal. It's only just giving you that information ahead of time. And so if most of the embryos are normal, it's not really helpful, because the chance that I'm going to pick a normal one is very high. But so in that 35 plus range, it becomes even more useful in the sense that the percent of abnormal embryos statistically overall is going to be 50% plus. And so that's where those numbers are kind of coming from. And again, I tell people it's hard to know exactly because statistics are useful for research, but in an individual, it's either going to be normal or not. And ultimately, it's very hard for us as humans to kind of really understand what that means for us. And so you do, to some extent, have to take it with a grain of salt. But you certainly do have to understand that, yeah, lots of embryos are abnormal. I think that's really, really the take-home point. Now, is there something about IVF that makes those embryos more likely to be abnormal? Because most kids are normal. So how is that possible? And that's because, as we talked about, most of these abnormalities are never going to get born. They're just they're not going to implant, or they're going to end in early miscarriage, which is very, very common. And so that's why we're kind of seeing with IVF, we're seeing all these embryos that sort of would have never seen the light of day, right? And that's why we see so many abnormal embryos.
Oftentimes I get patients that ask, well, doctor, what's your opinion? Do I need to do this or not? Should I do this or not? And I say, if you're 35 years old or older, the recommendations definitely support that doing this will lead to a pregnancy sooner and quicker than had we not done it. So if you needed a baby like yesterday, absolutely, PGT would be a smart way to go. Younger than the age of 35, it becomes a personal decision as far as, do you want the peace of mind of knowing that you are transferring something that may not result in a miscarriage or may not result in something such as trisomy 21 or Down syndrome?
Yeah, I think a lot of patients, when they think of PGT, that they want to do PGT because they don't want, especially the older patients, because they don't want to have a Downs baby. But then you have to explain, okay, well, you're 40 years old, so your chance of having a Downs baby is 1%. And when we look at embryos, that's what we're seeing too. We're not seeing that you have a bunch of Downs embryos that we're not putting in. It's a lot of other chromosomal abnormalities that are just allowing you not to have a miscarriage, and then allowing us to put in a chromosomally normal embryo. I think one of the real benefits of PGT. So first of all, PGT, if you take away the benefit that you get from not putting an abnormal embryo in, which, a Down syndrome baby, if you're just looking at, what are your chances of having a live birth? PGT does not improve your chances. Okay, it improves your chances for a single transfer, but if you use every embryo that you make, you're gonna have the same outcome as you would if you did PGT, got rid of the abnormals and used the normal embryos. The difference is you're going to get pregnant, in general, get pregnant faster because you're going to pick out the normal ones. The other benefit is that for patients who may have 2 embryos left frozen after they're pregnant, if you've done PGT, you at least know that those embryos are normal, and you're saving them for 3 or 4 years to use them. But if you're 38 and you have 2 embryos frozen and they're both abnormal, but you don't know that, and you think that I'm going to come back when I'm 42 and use those embryos, well, you're just wasting time, and because those embryos aren't going to make a baby. And so certainly, I find that that's a huge benefit for patients, having those extra embryos tested, knowing what's left frozen, what their future can be, or do they need to do another IVF cycle in order and get more embryos, or do they really just have time and they can wait to put them in? Because the other thing is, once you have a embryo that's frozen and you're 32, when you come back at 42, you still have the same pregnancy rate as a 32-year-old with that embryo. And if it's chromosomally normal, the uterus doesn't seem to age very much. So the pregnancy rate doesn't really change much with age with the uterus, unless something happens to the uterus. You get fibroids or some other procedure that would compromise the uterus. But in general, over time, the uterus doesn't really, it doesn't diminish its potential of implantation.
Yeah. The interesting thing is the success rate with a chromosomally normal embryo is approximately 70%. And of course, that's going to depend on who we're putting the embryo in and all that, right? But it doesn't vary much by age. And, because the effect of aging, as Dr. Frederelli mentioned, it's really affecting whether or not that embryo is going to be chromosomally normal. So if we know that embryo is chromosomally normal, we've kind of cut that piece out. And so that's kind of one of the really neat things about testing. You really know what you have in the bank.
And as you alluded to earlier, the increasing aneuploidy or abnormal embryos as someone ages, that really is the reason why older patients have more trouble getting pregnant than younger patients, right? Because if they have a chromosomally normal embryo, the pregnancy rate is going to be almost the same. It's just that when you're 32, you're much more likely to have a normal embryo to put into the uterus than when you're 42. But if you're 45, pregnancy rates are extremely low. But if you get a chromosomally normal embryo, now your pregnancy rate's very high. So it's just a matter of getting that chromosomally normal embryo and knowing if you have it.
Right. And that kind of goes back to IVF as a concept as well, because even when we weren't doing testing, for some crazy reason, right, we know that we need X number of embryo or X number of eggs to be able to get an embryo that's going to get you pregnant in the end of that. And so I always tell patients, I'm like, listen, I'm sorry that, you end up with 1 or 2 embryos from 20 eggs. But when I tried to get 20 eggs from you, it's not, I didn't want you to have 20 babies. It's because I know that there's this reverse pyramid, this attrition, which is very likely the result of abnormalities in these eggs, right? And that process of embryo development early on that we're not even testing, because those embryos aren't even making it to that stage where we typically do that testing. And so it's those embryos that kind of made it to that blastocyst stage, to the very final stages, that are most likely to be normal, and still are not always normal, right? But that's a huge part of why we really need so many eggs to be able to get a good embryo at the end of it.
Right. Yeah. I mean, I always tell my patients that, as humans, we don't reproduce very well. Our gametes are not very good at making babies, unlike mice and other animals, which can reproduce very easily. We're not very good at it because we make a lot of errors. We make a lot of chromosomal abnormal embryos that just can't implant and don't make babies. And even those young donors that you were mentioning, women in their 20s, they still need 8 to 10 embryos on average to make a baby. Or 8 to 10 eggs on average to make a baby.
Yeah. So what do you guys want to talk about? Other types of PGT?
Sure.
PGTM?
Yeah, there are other types, as you had alluded to earlier. These other types of PGT are used less commonly, and they're used in select individuals. These are individuals who we know that there is a specific genetic or chromosomal problem. And under those circumstances, we might think that PGTM, which stands for Preimplantation Genetic Testing for Mutations. So if you know you have a specific condition in the family, whether that be hemophilia, sickle cell anemia, cystic fibrosis, you know that disease exists, or if we've picked up that both you and your partner are carriers for that condition and that your child is at a risk for inheriting that condition, if we know what we're looking for, we can test the embryo for those things. It is not an easy process to do PGTM. It does take custom engineered specific probes that requires blood samples from both parents and sometimes extended family. This goes off to a genetic company where individuals with PhDs engineer probes specific for your embryo. So there's a little bit of time involved in creating these probes if you know you have a condition that you're worried that your child will inherit. Similarly, there's another type of testing that we can do called PGT-SR, which stands for Preimplantation Genetic Testing for Structural Rearrangement. Typically, those sort of things are diagnosed if you've had a history of recurrent pregnancy loss, and there is karyotype testing that have been done on one and both or both of their parents that has shown that, there is a complete set of DNA, but part of that DNA, maybe it had broken off and was repaired correctly in the cell, or the cell attempted to repair it, but maybe glued back on part of the chromosome upside down. And so when it's trying to match up with your partner and multiply and replicate and recombine, it can't match up correctly, what causes ultimately those miscarriages. But you as an adult, you have a full set of DNA. You have all of the bits and pieces that you need in order to make a fully functioning, healthy human being. It's just not going to be able to replicate well in order to create a baby. And so with PGT-SR, we can also, if we know what structural rearrangement in the chromosomes we're looking for, we can also test the chromosomes to see which of the embryos may be affected with that structural rearrangement.
So that's also called, those rearrangements are typically called translocations. And I kind of think of it as the chromosomes being kind of like stuck together. And so when the process of them sort of lining up to split, they don't all split properly. And so some eggs or some sperm, it's equally can be, the eggs or the sperm can have this. Some of the eggs or some sperm will have more genetic material than the other. And some will be balanced. So some will have, and this depends on the rearrangement too. I mean, it depends on the translocation. So there's kind of different ways. But overall, the idea is that some will be normal, some will be abnormal, some will be balanced, where they'll have the same translocation as the parent, but they'll have the balanced complement. And so PGTSR can help kind of tease all that out. And this is most common in patients, as Dr. Goulet said, who have a history of recurrent pregnancy loss, although some of them actually will present with infertility or kind of other concerns.
Yeah, I think one thing that some patients will be concerned about, and rightfully so, is that will the technique that's being applied, cause harm or damage the embryo? And I think the answer is always, it's unlikely, but the reality is you get in car accidents and things happen, unfortunately, and we are dealing with microscopic cells. The techniques that are used are done to such an extent that the risk is exceedingly minimal. But we are taking a few cells from that embryo. In general, there has to be enough cells in that trophectoderm component to take a few and leave enough behind so that embryo is not damaged. And so we do look at those embryos very closely to make sure that there is enough cellular trophectoderm, so that when we remove some of the trophectoderm, there's plenty of cells left for a normal placenta to develop and occur. And should we think that there's not enough, then in that case, the embryo is not biopsied and not tested, because we don't want to harm that embryo potentially. And so that's one way that we prevent us, we don't harm the embryos. And then we have to tell the patient, okay, well, this, you can only have 6 of your 8 embryos tested because of this reason. But that doesn't mean you can't use that embryo, because it still may be normal. It just couldn't be tested.
Right. One question that I always get asked too is, how long does it take to get these results back? So for the typical PGT, the PGTA that we talked about, looking at aneuploidy, that takes about 2 weeks. And usually it doesn't really add much time to the cycle, because as most patients are doing frozen embryo transfer cycles, we can just start that process of preparing you for the frozen embryo transfer. And that we're going to get the result back before the transfer. So it really doesn't take away time or add time. The PGT-M, looking for specific genetic mutations, which Dr. Goulet mentioned, PhDs are on the lab engineering probes specifically for your embryo. That process will take more time. Ultimately, once the probe is ready, then it'll take maybe 2 weeks to get the result. But it's just going to take some time to kind of prepare that case. So there's definitely some preparation process involved ahead of time with that. What else? Can PGT be done if we're using donor sperm or donor eggs? Yes, absolutely. That's another question people ask. As we mentioned, people who are doing donor egg cycles, even though the rates of aneuploidy are lower, they're still 30%. So it's still kind of reasonable to do in that setting if it makes sense for you.
So the other thing that people obviously are always concerned about and ask about is cost, right? And I think that one thing to realize is that we have about 60% of our patients will do PGT for various reasons. There are certainly some centers across the country that are 90+%, where almost everyone's doing PGT. And so it does vary from center to center, but and a lot of it's cost and how much extra money people have to put into their treatment. What I always tell my patients is if this was free or covered by insurance, we would just do it on everybody, because there's no reason to put an abnormal embryo on somebody. There's no reason for somebody to have an embryo that's frozen. They think that they can use it in the future, and they shouldn't. But because of the cost, there is a large percentage of patients who may not choose to do it. And the cost is hefty, and it involves obviously the biopsy part of what the embryologists are doing, the embryology procedures, the shipping cost to the genetics company, and then all of the genetic testing. And it ends up being about $5,000 if you end up testing up to 10 embryos. And if you have fewer embryos that are in the less than 5 embryos, then it's going to be a prorated cost for patients per embryo. But it does vary depending on what you're doing too. If you're doing the PGT-M or PGT-SR, there's extra costs associated with that because of the extra test. However, if you're doing that for a known family disorder and you have insurance, a lot of times the insurance will cover that cost. They won't cover PGT-A for any, just looking to see if it's a normal embryo or an abnormal embryo. They won't cover that cost but they will cover if there's a disease that's being prevented in your family because you have a family history of cystic fibrosis, or you're both carriers for cystic fibrosis. Then they will cover the PGT with the PGT-M part of that.
The way to test for that, by the way, is genetic carrier screening. So the way to test to see if you're a carrier for a disease that runs in your family, or if you're a carrier for anything, is a genetic carrier screening that many fertility clinics, including us, we offer that to our patients. So that's something that you can ask about. Some insurances cover. Some don't cover that testing, but it is a blood test that one or both partners can do to determine if they're carriers for anything, and if PGT-M, the mutation testing, would be useful.
And didn't we do a live stream on that a few months back?
Did we do it? Maybe.
I
don't know.
They blend together after a while.
Or maybe it's coming out. What'd you say?
I was going to say the American College of Obstetricians and Gynecologists and the American College of Medical Geneticists do recommend that we offer that to all of our patients, and we certainly do. The panels that we're using now can screen for over 450 some conditions. These conditions are generally considered relatively rare, so you may not see a family inheritance pattern. You may be surprised when you get a report back that comes back with a condition that you may have heard of before, such as muscular dystrophy, or may have never heard of before. I can't even pronounce some of them. But because of the rarity of these conditions, you don't see that traditional familial inheritance pattern where you can see it in every generation or in your aunties and uncles. Sometimes you may have everybody in the family that's healthy, and unfortunately there have been children that have been affected with these conditions. So the conditions chosen for the panel are typically diseases that if a child were to be born with would severely affect the quality of life of an infant or the duration that infant would live. Every now and then, some of these diseases can have what we call variable penetrance or a variable phenotype. So they may include a spectrum where a child could be affected, or you may not be affected until adulthood. And so every now and then I'll see a report back where I'm telling an individual about the fact that the carrier report has diagnosed that they're not just a carrier, but they may have 2 affected genes of that condition. So those are some of the things to be aware of when we do that genetic testing. But overall, most people do find it very informative and helpful in their pursuit of having a healthy live-born child. But similar to the limitations of PGT-A, it can't pick up every disease. There are tens of thousands of genes or more in the human genome, and we're just looking at a handful of genetic diseases in that carrier testing.
I think that's important to realize too. I get, when I guess going back to I started this at the beginning. When I start talking about PGT for patients, I kind of explain, okay, well, the chromosomes are the big building blocks of your genetic code. And we have, 23 pairs of chromosomes. If you count the two X's or the X and Y as a pair, they're numbered 1 through 22. But then on those 23, pairs of chromosomes, there's 30,000 genes that we're not testing, right? And so there certainly can be some genetic issues that might come around. But what you're looking for is it's the big building block issues that cause an embryo not to make a baby initially, or miscarriages. But the genetic screening tests that we do are designed to look for those genetic disorders that we do see in babies most commonly.
The other thing to note is that you might have diseases that run in the family that are not simple genetic disorders that we can test for. So it's like, I have there's autism in my family, but they don't know the genetic. It's not a kind of known genetic condition. In that case, well, if we don't know what it is that caused it in your family member, we're not going to be able to test the embryo for it. There's certain mental health disorders and things like that.
And you can also have de novo mutations, where you'll have a mutation and you'll get a deletion in a chromosome, and then you may have a child with that's affected. I think it's important to realize too that it's the percent of babies that are born with some type of abnormality is somewhere between 3 to 5%, depending on the data that you look at, and that's regardless. Even if we're saying it's a normal embryo, 3 to 5% of babies are still going to have some kind of abnormality, an extra digit, a heart abnormality, something that is that people see. So it's not uncommon that babies are born with some kind of abnormality that's not necessarily at least chromosomal in nature, and it's probably multifactorial.
Right.
Sometimes I have patients come to me and say, "Oh, well, I've already done 23andMe. I don't need to do this." These are not the same genes that are tested for in some of the popularly retailed ancestry panels or 23andMe. Or I'll have a patient come to me and say, okay, well, my mother died of breast cancer. I'm really curious to know if I'm a carrier. I'm looking forward to the results of this genetic carrier screening test. And while those sort of testing can be done, those aren't the genes that are looked for on these panels, because these panels are customized to generally towards diseases that would affect an infant. And so if you do have other genetic concerns in your family, for example, a breast cancer gene, talk to your doctor about it. There's certainly testing that can be possible for it, but those won't be included in the carrier testing panels.
Yeah, the majority of these tests, that they're looking really at recessive disorders where typically, for the most part, where you need two of these genes to be affected. So the majority of the time, you're not going to get a result back. I'm not going to call you and say, "Oh gosh, looks like you have this deadly disease. Sorry." You're not going to get that result back, which I think some people are worried about. It's really going to be you're a carrier for this thing. And maybe your partner is a carrier for this thing. Now, you guys are both fine and healthy, but if you have offspring together, then there's a risk to your offspring, but not to you guys. That's really, for the most part, what this testing is looking for. I don't know. I feel like we covered a lot of stuff.
Yeah.
I think we have. Any last comments?
No, I think we really covered a lot, and I don't know, I'm getting tired.
Well, thank you, Dr. Carmone, and thank you, Dr. Goulet, for all of your expertise today, and thank you everyone for joining us. And mahalo. See you next month.
See you next time. Bye,
See you
guys.
soon. Bye.